chronic pain, interrupted routines, and the constant debilitating fear of an agonizing flare-up. If external hemorrhoidal disease is actively controlling your life, you're facing a painful trade-off. Endure the suffering or risk a potentially traumatic surgical recovery. This is the agonizing dilemma millions face every day. Welcome, or welcome back if you're returning. I'm Dr. John Chuback, and we're talking about one of the most critical and painful debates in surgical management: the choice between leaving a troublesome external hemorrhoid alone or opting for surgical removal. We're going to break down the modern evidence and show you exactly how minimally invasive techniques have fundamentally changed this risk-benefit equation. Thank you for being here, and thank you for your continued support and excellent engagement. Your commitment to seeking definitive evidence-based solutions is what drives this channel. The external hemorrhoid dilemma: endure versus excision. The specific question we're addressing comes up constantly and captures the deep internal struggle of patients living with this condition. I have a debate as to whether I should leave my external hemorrhoids alone or remove them. I can't go on living like this, but the cons of the procedure seem to outweigh all the benefits. Can you help me, Dr. Chuback? This debilitating trade-off, suffering versus surgical fear, is typically rooted in stories about outdated, highly aggressive hemorrhoidectomy procedures. Our entire discussion today will center on how modern, targeted surgical approaches shift this painful calculation dramatically, offering a path to definitive cure with manageable morbidity. Understanding the complex pathology. To properly address the debate, we must first establish clear anatomical distinctions. The condition is called hemorrhoids, but refers to an abnormal descent, engorgement, or thrombotic event within the normal vascular cushions of the anal canal. External hemorrhoids are located below the dentate line, the anatomical landmark that separates the insensitive lining of the upper anal canal from the highly sensitive skin, known as the anoderm, covering the lower portion of the anal canal and what we call the anal verge. The key characteristic of an external hemorrhoid is its location within the purview of the pudendal nerve, meaning it's being innervated by the pudendal nerve, giving sensation to that area. This means that the tissue is densely innervated by somatic sensory nerves, which is precisely why an external hemorrhoid becomes exquisitely painful when it swells, becomes acutely thrombosed, or is manipulated surgically. Conversely, internal hemorrhoids originate above the dentate line in the columnar epithelium. This area lacks the somatic sensory innervation. This distinction is why internal hemorrhoids typically present with painless bleeding or prolapse, while external hemorrhoids present with pain, swelling, and chronic discomfort. External hemorrhoids are often the end stage of prior pathology. A common scenario involves a prior episode of acute thrombosis, or clot forming in the external vein, which the body subsequently resolves. The residual tissue left behind is often referred to as an anal skin tag, a flabby, often benign fold of skin and fibroelastic tissue. While not painful itself, chronic or repeated episodes of swelling and thrombosis can lead to significant skin tag formation and induration. This chronically enlarged tissue can impair hygiene and make thorough cleansing difficult, leading to chronic moisture, irritation, and perianal dermatitis. This can also cause mechanical irritation. The persistent presence of rubbing can cause local inflammation and discomfort, a dull chronic ache, rather than the acute pain of thrombosis. And then there's a psychosocial impact. The physical manifestation of the disease often causes patients to restrict activity and social interaction due to self-consciousness and discomfort, leading to profound reduction in quality of life. The decision to intervene is contingent upon a full understanding of two variables: the specific pathology present, is it a skin tag, a chronic mass, or an acute clot, and the potential morbidity of the treatment. Let's talk about the non-operative mandate, indications for deferral. It's absolutely paramount to recognize the clinical scenarios where surgical removal is unwarranted. No surgery, no matter how minor, is without risk, and adding morbidity without commensurate benefit is poor medical practice. So let's begin with asymptomatic skin tags. If the patient presents with a history of past hemorrhoidal events, but the current residual tissue is entirely asymptomatic, painless, non-inflamed, and not causing hygiene issues, That tissue is classified as an anal skin tag. This is benign fibrous tissue. Removing it requires an incision and creates a surgical wound on the anoderm, leading to temporary postoperative pain and downtime for zero functional gain. For these patients, I strongly recommend a hands-off approach. The discomfort of the recovery is never justified by the purely cosmetic benefit. Now, if the patient is absolutely emphatic that they want these skin tags to be removed, it can be done, but they may experience some pain in the healing process, and that has to be very, very well described beforehand. Now, if the patient experiences only mild, infrequent symptoms, like occasional itching, slight swelling after heavy lifting or straining, but quick resolution, then a non-operative, lifestyle-based approach is the gold standard. This is the first line of defense for all hemorrhoidal disease. So let's talk about the pillars of conservative management. First is dietary fiber supplementation. The goal is to produce soft, bulky stools that pass easily without excessive straining. This minimizes vascular engorgement and trauma. Patients should aim for 25 to 35 grams of total fiber daily. This typically requires a supplement, for example, psyllium husk or methylcellulose, in addition to their normal dietary intake. The mechanism is simple. Bulk reduces straining, and less straining reduces less pressure on the venous cushions. Next is hydration and bowel habits. Adequate water intake is essential to allow fiber to work effectively and prevent the formation of hard, desiccating stools. Furthermore, patients must avoid prolonged sitting on the toilet, limiting sessions to less than 5 minutes, and never ignore the urge to defecate. Straining or sitting too long increases intra-abdominal pressure, which directly engorges the hemorrhoidal plexuses. Now let's touch on topical agents. These are used for symptomatic relief during mild flares. These typically include corticosteroid creams used for short periods, less than 7 days, to reduce inflammation and swelling, or local anesthetics to temporarily numb the area to control pain, like a lidocaine jelly. There are also protectants like barrier creams, for example, those containing zinc oxide or petrolatum, to protect the irritated skin. And of course, one of my personal favorites, phlebotonics like flavonoids, certain oral agents like micronized purified flavonoid fraction or MPFF, which have been demonstrated to have efficacy in reducing capillary fragility and increasing venous tone, providing systemic support for hemorrhoidal symptoms. For patients whose symptoms fall into this mild intermittent category, embracing this strict lifestyle regimen will often achieve sufficient comfort without the need for surgical intervention. Now let's talk about when intervention is indicated, and we're going to address the morbidity of those procedures. The moment a patient says, "I can't go on living like this anymore," the discussion shifts. The primary indication for intervention is the patient's own statement that the hemorrhoids have demonstrably and significantly degraded their physical function or psychosocial quality of life. When chronic suffering outweighs the temporary discomfort of surgery, intervention is justified. If external hemorrhoids are chronically prolapsed, consistently inflamed, causing significant hygiene challenges, or resulting in recurrent pain and bleeding that fails conservative management, direct excision becomes the most effective, definitive long-term treatment. This is not simply removing skin tags, it's excising the redundant fibrotic and problematic vascular tissue that perpetuates the cycle of inflammation. This procedure aims for cure, not just management. A specific and urgent indication for surgery is the presentation of an acutely thrombosed external hemorrhoid, a sudden, rapid pooling of blood in the external venous plexus that clots, creating a hard, blue, exquisitely painful lump. The pain is immediate, severe, and constant, often described as throbbing, because the clot causes tension and pressure on the surrounding, highly sensitive anoderm. The treatment window for this specific condition is critical. If the patient presents within 72 hours of the acute onset of pain, a prompt in-office excision of the thrombus and the associated hemorrhoidal vessel under local anesthesia is the recommended course. Removing the clot and the vessel wall immediately relieves the tension, providing the quickest and most profound relief. Excision is superior to simple incision and drainage, which just removes the clot, because excising the entire thrombosed vessel reduces the likelihood of recurrence in that location and prevents the formation of a large symptomatic skin tag. If the patient presents beyond 72 hours, the body's already initiated the natural process of fibrinolysis and organization. The clot begins to harden and resolve. At this stage, stage, the peak swelling and pain are often subsiding. The pain and morbidity associated with the surgical incision and wound care often outweigh the residual pain from the diminishing clot. Therefore, the management typically shifts back to conservative measures like sitz baths, pain control, and micronized purified flavonoid fraction, horse chestnut, and associated dietary supplements like those. This allows natural resolution. The fear of surgery is largely rooted in the traditional excisional hemorrhoidectomy, like the Milligan, Morgan, or Ferguson techniques, which involved comprehensive removal of all internal and external tissue bundles, leading to large wounds and prolonged healing. The modern, targeted approach for isolated external disease is vastly different and has a much improved morbidity profile. When the pathology is strictly confined to the external component, the procedure can be performed in the outpatient setting under local anesthesia alone. This is not the full-scale removal that causes weeks of pain. With this sort of procedure, meticulous infiltration of local anesthetic like lidocaine with epinephrine, for example, is used to precisely numb the anoderm surrounding the subcutaneous tissue around the hemorrhoid. This is the single most important step for intraoperative comfort. An elliptical incision is used to excise the entire problematic mass, including the whole hemorrhoid itself, whether it's a chronically fibrosed hemorrhoid, a large skin tag causing hygiene issues, or an acute thrombosis. The elliptical shape of the excision is critical because it creates a nice linear scar that comes together beautifully and heals very, very nicely, minimizing the chance of developing what we call a keyhole deformity or a dog ear. And this allows for clean, healthy wound margins and excellent healing. In this sort of hemorrhoidectomy, the involved vessels and any redundant tissue are carefully dissected free, and all of the bad tissue is taken away, leaving the healthy tissue behind for closure. Obviously, a good surgeon wants to achieve complete hemostasis, which means there's no bleeding whatsoever after the hemorrhoidectomy, and sometimes a little bit of electrocautery can be used to seal any small bleeding vessels. For small, clean excisions, the wound is sometimes left open to heal by what we call secondary intention, and that promotes drainage and reducing the risk of any abscess formation. The wound size is always minimized. This is done to create faster, less painful recovery. Let's contrast the targeted in-office excision with the old traditional approach. The modern targeted in-office excision is performed right in the office or in an outpatient setting using only local anesthetic to numb the area around the hemorrhoid. Sometimes light sedation is also used. This is critical because it avoids the costs and logistics of an operating room, which is generally required for a traditional hemorrhoidectomy, where the patient receives general or spinal anesthesia. The targeted excision is minimal and necessary, focusing only on the specific external symptomatic vessels. Conversely, the traditional approach often involved the comprehensive removal of both internal and external tissue across 3 quadrants. This focused approach dramatically improves recovery, and the old-style approach is fortunately rarely employed anymore. For a targeted excision, we see a significant functional return and resumption of normal activity within 7 to 14 days. Compare that to a traditional hemorrhoidectomy, which typically required 2 to 4 weeks for initial healing, with a full return to strenuous activity often taking up to 6 weeks, along with greater initial pain along the way. Finally, pain management is easier to control with the targeted method. It's manageable with a structured, multimodal, non-narcotic pain regimen for most patients, whereas the larger surgical defect of the traditional procedure often necessitates stronger opioid analgesics for a longer period of time. While a focused excision is far less traumatic than a full hemorrhoidectomy, it is critical to set expectations. Post-operative pain is unavoidable. Any incision in the highly innervated anoderm creates a wound that must heal. This wound is stretched by every bowel movement. It's sort of like having an anal fissure, although it's not, but it does give you pain every time you're going to have a bowel movement. And this can be very, very unsettling for some patients. Success hinges entirely on meticulous post-operative care and patient adherence. The multimodal regimen of pain control means that the goal is to prevent pain from starting rather than chasing it after it's become severe. And this multimodal regimen utilizes multiple classes of medications targeting different pathways, allowing us to minimize and eliminate the need for opioids, which cause constipation and can worsen the problem. So we start with NSAIDs, non-steroidal anti-inflammatory drug. These are taken around the clock, for example, ibuprofen, to control inflammation and contain pain at the surgical site. Acetaminophen can also be used simultaneously with the NSAIDs for a synergistic effect. And then, of course, topical anesthetics like a prescription-strength lidocaine jelly or similar topical agent applied directly to the wound before or after bowel movements to temporarily desensitize the area. Some surgeons will use a long-acting anesthetic at the time of surgery like bupivacaine, which is injected right at the time of surgery and may provide up to 2 to 3 days of significant local pain relief. This cushioning of the patient through the first 48 hours is very valuable in so many cases. Then we come to bowel management, which is a priority. The single most painful event postoperatively is the first bowel movement. The surgeon's strategy here is to ensure that that stool is soft, bulky, and easily passed. Softness prevents tearing and pain. Bulk provides a clean mass that doesn't fragment. Stool softeners like docusate sodium can increase the water content of the stool, making it softer and easier to pass. They must be started before the surgery and continued rigorously afterward. And then we have fiber bulking agents like psyllium husk. These must be resumed immediately postoperatively, and as discussed, they create a necessary bulk to ensure clean evacuation of the bowels without excessive wiping or straining needed. The combination of stool softener and fiber is critical. Crucially, fiber must always be taken with plenty of water to prevent the fiber from causing an obstruction. Then there are laxatives if needed. A mild osmotic laxative like polyethylene glycol may be temporarily employed if the patient is unable to have a bowel movement postoperatively by day 3 or 4. But the initial focus is definitely on softeners and fiber. Many physicians also recommend MPFF and horse chestnut for their anti-inflammatory and antioxidant effects to also help with comfort after a hemorrhoidectomy. Now let's touch on wound care and hygiene. Sitz baths can be very helpful. This is a warm water soak and it's a cornerstone of recovery. They're recommended 3 to 4 times a day and immediately after every bowel movement. The mechanism is that warm water acts as a muscle relaxant, reducing the severe spasm and reflex tightening of the anal sphincters. That causes much of the post-operative pain. The water also cleanses the area gently, promoting wound hygiene and reducing the need for abrasive wiping. The technique is quite simple. You use plain warm tap water, no salts or harsh soaps are necessary, and you soak for 10 to 15 minutes. After the soak, you gently pat the area dry and do not rub that area. That's very important. In terms of a dressing, you typically can use a small dressing or a gauze pad to simply absorb any minor discharge and protect your clothing. It's not meant to compress the wound. Let's talk about some expected recovery milestones. Understanding the timeline helps manage psychological stress and adherence to the regimen. In day 1 or 2, you're going to have peak swelling. Pain is going to be controlled primarily by long-acting nerve block if it was used, and the swelling around the surgical site is definitely maximum at this point. Focus on pain medication and initiating the bowel regimen, as well as dietary supplements like MPFF and horse chestnut. The peak pain will come with the first bowel movement. After the local anesthetic wears off, pain peaks and is usually most intense during and immediately following defecation. This is when patients often want to give up. Rigorous adherence to sitz baths and pain medication is critical. Now, in week 1, this becomes a turning point. The initial swelling begins to subside significantly. The pain intensity starts to show a sharp decline. Functional movement improves. Patients often report being able to sit comfortably for longer periods. In week 2, we start to see more functional return. The majority of patients can return to work with light exercise. Residual discomfort may remain, particularly with exercise or extended sitting, but the acute debilitating pain is gone. At week 3 and 4, we're getting to full healing. The wound is typically closed and epithelialized, and the surrounding tissue may remain firm for a few weeks longer. Full return to all activities, including strenuous exercise, can occur at this time. The patient who chooses excision for chronic debilitating external hemorrhoidal disease is trading several years of suffering for a controlled, temporary, and predictable period of discomfort, a trade-off that's overwhelmingly favorable for long-term health and well-being. So in conclusion, what I would say is this is an important decision for the patient. And ideally, this is for the patient who chooses excision for a chronic, debilitating external hemorrhoidal disease situation and is trading several years of suffering generally for a controlled, temporary, and predictable period of discomfort, a trade-off that's overwhelmingly favorable for long-term health and well-being in the vast majority of patients. I hope this video was helpful. helpful for you. It's an important conversation. I thank you as always for tuning in. I hope you'll like, subscribe, and share, and I will see you in the next video.